Let's move on to the next one. Thanks a lot. Let's bring the next person in, Jane, if we may. We have Lucy Morgan from the strategy unit presenting with support from Sally Thompson. And here they are. Excellent. So while you're just getting your slides ready, this is all about modelling renal care from progression to diagnosis. And we're just about there. Excellent. We can see the slides. Off you go.
Right. Okay. Just unmuting there. So thank you very much. Okay. So hi everyone. Great to be joining you today for HACA. I'm going to be presenting today our model of renal care, which looks at the whole path of renal care from chronic kidney disease all the way through to kidney replacement therapy. This is work that myself and Sally have been working on for quite a long time now. Sally is a system dynamics expert and has been building our kidney progression model, our kidney disease progression model, I should say. And I'm a discrete event simulation modeler and have been building the kidney replacement therapy patient pathways side of the model. So together we've combined our knowledge of system dynamics and discrete event simulation to bring together a model that's hybrid in using two different simulation methodologies and kind of combines, I guess, the best of both of our skills, which is quite an exciting thing to do. So I'll take it away to tell you a little bit more about the model and give a little demo as well. So this project is basically something that was motivated by the Midlands Kidney Operational Delivery Network. So they came to the strategy unit with some concerns about the capacity for in-centre dialysis over time, and they wanted to see what we could do in terms of modelling to try and look at that problem. So to kind of give you the backdrop of kidney care at the moment, so we know the challenge is that we don't have sufficient capacity to meet the future needs for renal services. A lot of modelling has been done as to what's going to happen in future, and they're all pointing to the same kind of picture where the people going into kidney replacement therapy or the incidence to kidney replacement therapy is growing and growing over time. We're not going to, given our current infrastructure, have the capacity to treat all of those people. So need is growing because population is growing and the health profile is changing in the population. Now, we do have an opportunity due to changing models of care to provide better quality of care and more equitable services, but we think it's actually, because of the complexity of the system, it's actually really difficult to predict and project the likely effect of different interventions on the system without using something like simulation. So we've taken a simulation approach to try and model this system. So why simulate? Well, simulation allows us to kind of look at the interconnectedness of a system that's very complex. It can allow us to explore feedback interactions and also do interventions within the system on a model of the system instead of in the real system itself. So in effect, we are playing out interventions in a risk-free environment. So in healthcare, I mean, in many situations, that's a good thing to do, right? Because you don't want to risk doing something bad in your real system. But in healthcare, where people are at the heart of what we're doing, we don't want to play with a system if we think that there could be potential patient harm at the end of that. So basically, what we're trying to do is give them a model that they can test out interventions on in a safe environment, create that evidence-driven evidence-led business cases, I guess, to actually make changes to the system in future. So there are a number of different ways that we've suggested that the model that we've built could be used by people in renal care. It could be used for testing individual intuition about how impactful different interventions could be. For supporting collective decision making, so people coming together to try and work out what the best and most strategic thing to do next is, and then informing and evidencing future plans. So giving people the evidence they need to say, this is a good thing to do, this is the impact that we think it will have, and then and try and get the funding to actually act on that. Okay, so an umbrella of the objectives of what we were trying to do, and these have developed over time, were firstly to try and look at how demand is going to change over time for kidney replacement therapy, what that means in terms of capacity. How can we influence that by looking at upstream interventions, so things in the chronic kidney disease pathway, and how can we influence it downstream also, so directly within the kidney replacement therapy pathways by influencing things in the system. And then also looking at the relative cost of each intervention versus a baseline no change or status quo type scenario where we project forward if nothing was to change over time, what might we see? Okay. So, as I said, we've taken a hybrid approach to modelling renal care in general. Now, the two different models, they were both informed by a participative modelling approach, which is something that we at the strategy unit try and advocate for. Basically, we're trying to bring the clinicians, the nurses, the commissioners, all different people that would interact with the renal pathway, and even the patients themselves. We are trying to engage them with the model, bring them along the modelling journey with us, so that when we get to the point of actually showing them the outputs of our model and some of these what-if experimental scenarios, that they then trust the model because they've understood how we've built it and that we've reflected something that is their real system back to them along the way. So participative modelling is something that we've done throughout the project. And we'd just like to acknowledge that Marie and Mark from Midlands Renal Network have been our lead stakeholders here and have been helping us throughout the project make sure that we're engaging with all of these different people, but also have been really responsive throughout themselves. And also Antoila Taco from Loughborough University has been there for the I guess I don't want to say educational, but simulation expertise as well as a backup for us to ask extra questions, which has been great. Okay, so this is at a high level our model of renal care. I've put it in two boxes because they are two separate models, but they are linked. So we could think of this as a sequential hybrid model. The first model represents CKD progression. So we're thinking about how people get progressively more and more ill, having been with chronic kidney disease over time. And then at some point in their journey, they develop end-stage kidney disease and they require kidney replacement therapy. And it's the incidence into kidney replacement therapy that we're interested in from that model that we can then feed into our second model. So the KRT incidence from our first model actually drives our second model because it actually pushes patients in at a rate, it governs the rate at which people are pushed into our second model. Now, the second model is of the actual kidney replacement therapy service. So it looks at all the different pathways that patients can flow around that system. So are they in dialysis? Are they at home doing dialysis or in centre? What type of dialysis is that? And maybe are they living with transplant or have they been put onto conservative management? So that is much more of an individual level model. So we're looking at individual patient movements, whereas in our original model, in the first model, the CKD progression model, we're looking at the flow of a population through a disease and how their disease progresses at a certain rate over time. So the first is modelled using system dynamics because that's all about looking at flows of population, and the second is using discrete event simulation because that's all about looking at individual patient movements through a system. So that's why we have chosen the two methodologies we have and combined them in this way. So it gives us basically, combining these models gives us a joined up picture of renal care. It allows us to play out upstream and downstream interventions and look at the impact of those in this risk-free environment, providing defensible evidence for the implementation of the renal interventions that are of interest to Midlands and also beyond. So let's just have a quick look at the CKD pathway. In our CKD pathway, people enter the system developing CKD, initially stage 3. So it's actually really hard to detect earlier stages of CKD. So we've let data govern that we start at stage 3 here. So initially they're undiagnosed. Most diagnosis occurs at stage 3, but some of them will worsen to stage 4 and 5 while still undiagnosed. Then diagnosis management can slow progression from stage 3 to stage 4. So we have a slightly different rate at which they flow from diagnosed CKD stage 3 to diagnosed CKD stage 4, as we do for undiagnosed stage 3 to stage 4, 5. And then the disease will get worse, and at some point, for some patients, mean that they require kidney replacement therapy. And mortality can occur from any of these different places. Now, what we've done with this model is we've looked at a number of different interventions in it, including primary prevention strategies that can reduce the number of people flowing into our model. So that might be something like smoking cessation or the new weight loss drugs, things like that, the impact of those on slowing the rate at which people are coming into the model. We've looked at increased diagnosis. Of course, if you're diagnosed, potentially you are having treatment for CKD, and therefore your rate of flowing from stage 3 to stage 4, 5 is slower. And also we've looked at, and this is one of the ones that we primarily looked at over the last couple of months, is medication. So how can medications be used to slow the rate at which people flow through the model? How can we slow their progression using things like SGLT2 inhibitors? Okay, right. Okay, so this model's useful because it projects our future CKD prevalence, and again, drives that second model for kidney replacement therapy. It can look at how prevention and drugs and new medications can impact CKD prevalence, and then again be played downstream into our KRT model to look at how that can impact capacity. Sally has built this amazing interactive, freely accessible tool, which I think she's going to drop the link to in the chat now, that will allow you to play with those different interventions. I was going to do a quick demo of that tool, but I might just leave that for the end, just so we've got time to quickly go through the kidney replacement therapy model as well. And again, we're supporting evidence-based long-term KRT planning. So if you want to, after this, I would suggest that you go and have a little play with that tool, because it's really user-friendly. And if you can see here on the left in grey, we've got different interventions that you can play with, and then you can see the impact of them versus a baseline status quo, do nothing type scenario. So you're basically seeing the impact of that intervention into the future population. Okay, I'll quickly now talk about modelling kidney replacement therapy using discrete event simulation. So as I said before, so we're using discrete event simulation here because we're looking at how patients specifically flow through the model. For this, I think I actually just missed it flashing up there. So our last model, in the CKD model, we're looking at regional and national level. For this kidney replacement patient treatment pathways model, we're also dropping that down as well to an extra level of granularity, where you can look at trust level data. So you can look at a kidney centre and see the capacity implications of from the model in that smaller, lower granularity model as well. So in our kidney replacement therapy capacity model, patients develop renal failure. So we've got that push through or incidence of people developing kidney replacement therapy from the CKD model that pushes people into this model. They then could go to conservative care, which means they don't actually receive care for kidney replacement therapy, but they are given almost like palliative care. Some patients might be suitable for transplant, and if they are, then they could have that preemptively, which means they have it before starting any dialysis or other treatment. And that could be a live or cadaver donor transplant, and then they'll live with it for some time until they die or their graft fails, at which point they join the start of the system again, i.e. they're judged as whether they're suitable for transplant and go through the same process. If they weren't, if they didn't have a preemptive transplant, then they progress to dialysis, and they're allocated to one of the 3 dialysis modalities in the model, so in-centre, home hemo, or peritoneal dialysis. And then after some time, they progress on to transplant, but not everybody will that's listed for transplant will actually receive a transplant in the model. If they weren't suitable for transplant, then they go straight to modality allocation, and they can change modality allocation throughout the time they spend in the model. And then there's a probability of death from any of the activities in the model, and that depends on the attributes of the patients flowing around it. So at every decision-making point within this model, the patient's attributes, like their age, their referral status, so whether they were an early referral or a late referral, for example, they all govern how that they move around this system. So the time they're in the system, the probability of them being suitable for transplant, etc., they're all governed by different probability distributions that are again governed by the attributes that that patient has. Okay, so things that we were going to look at intervening in this system, we're looking at moving people out of in-centre hemodialysis into home or peritoneal dialysis, so trying to take the pressure off the capacity problems that we're seeing in centre. Increasing diversion to conservative care, because there was a view, we wanted to build that into the model because there is a view that perhaps in some situations more people are being put onto dialysis than is potentially good for the patient. So we were looking at the impact of potentially increasing that in the future. Increasing preemptive transplants. So if we some hospitals do this really well. They get a patient in, they work them up very quickly for a transplant, and then they get the transplant done within a number of days. But that's not for all systems. It's not the same across the country. So can we find out the impact of improving that? And then also looking at the increase in live donors and donors basically in general is of interest. And finally, we'll look at the increase in decreasing late referrals into the system. So that's people that have not been detected as having chronic kidney disease and therefore not been identified as needing kidney replacement therapy, and they come in through emergency routes, and these people are they have much worse outcomes, or they've got the probability of them having worse outcomes is higher because of that late referral, i.e. them catching it further into their journey. So this pathway is useful because it allows us to look at the capacity requirements. It allows us to look at the impact of downstream interventions, so changes in those actual pathways, but also equally, if we run a preventative intervention in the CKD model, so we're looking at the chronic kidney disease population, and we do a preventative measure, which means fewer people are flowing into kidney replacement therapy, we can feed that into this model by changing that incidence profile over time that actually pushes patients into this model in general. Okay, so this model is, at the moment, it's available on our strategy unit GitHub. We're just finalising the open source version of this model, which runs in SymPy, which is a Python package for simulation. It comes with an Excel user interface where basically you design your scenario, so you pick your centre and your region and your incidence profile, and then any of the interventions you want to try out, and then you run the model in Python, and all the results are pushed back into Python, and you can see plots of prevalence over time, so versus the baseline. Okay, so I don't know if I've got a minute. I probably don't have a minute to actually talk about any of our future plans, so maybe we can just go to questions. Is that okay, Phil?
That'd be fabulous. That's what I was lurking
Great.
for. Yes, we've got the main stage back on in a minute or two. So, thanks. That's really interesting and a really complex modelling approach. So we've got a couple of questions. I'll smash into one, which is how you essentially stress tested all of this and how you ensured you understood the uncertainty.
Yeah, no, I think that's a great question. So as with any simulation project, both models have been validated on real world data. So the CKD model is validated on CVD Prevent data, which is a well-known data source. And the kidney replacement capacity model is all validated against the UKRR, so UK Renal Registry data. It was built using that data and then up to the end of 2022, and then we look at how it performs in the years 2022 to 2025 to see is the model actually performing well on a test data set, for example. So we can do a number of things to check, but the process of validation, I think, is just as important as the process of model building. So I think that was a great question. Thank
Super. And we're just about time. You've got as ever the ultimate sign of respect from an analytical crowd of a demand to get into the nuts and bolts of the assumptions and parameters and code and all the rest of it. So that's over in the chat. I'm sure people can pick up with you on that afterwards. So I think that's all left for me to do is wrap up the session. So thanks to all of our speakers who've been fantastic. Thanks to the people organised background, and thanks to all of listening. We'll not keep you on the main stage any longer. Stick around for networking afterwards. A real good project will come out of it, and you'll get to know some good people too. But yes, thanks very much, everyone.